Oh, Doctor, okay, how are you?
Hello, very well, thank you.
Nice to meet you. It's a pleasure, really.
Nice to meet you also. Thank you.
Very good. It's very good day to join us today and to share experience, of course.
Yeah.
And we're glad. We will start in a few minutes.
Okay.
The attendance in the last few days was great. It was above 100. But today, I think people are still behind. They will start soon. Dr. Honda, how are you?
Good. Thanks very much. Thanks for having me.
How is China?
I'm in Taiwan at the moment. And
okay, how's Taiwan?
It's quite cold. It's winter here.
Okay.
And we're getting ready for our New Year. so
the Chinese New Year.
Festive. Yeah, so it's quite festive at the moment.
Oh, it's nice. Thank you very much joining us.
My pleasure.
Dr. Licker from Switzerland. Have you introduced you to each other?
No, not yet. Hello.
Good to meet you, sir.
Nice to meet you too.
We have another Dr. Thomas from USA and Dr. Raja from India. So hopefully we will be on time for today, inshallah.
So we have noon now. What is the time in China now?
In Taiwan, we're at 7 in the evening.
7 in the evening, so yeah.
Yeah.
I did a small mistake that one of our speakers, she's from Australia, Dr. Janet Travis, for tomorrow. Her speech will be 3:30 p.m. in Saudi time. But I recognized lately that there is a 7 hours delay. So she will speak around 11 p.m. midnight. I'm sorry for that, but I'll try to solve this issue. PM is not bad in Taiwan.
No, it's still quite early here.
Still awake.
Yeah.
Is it a good place for tourism, Taiwan?
Yes, his internet is lost.
Yeah, it is a little bit. I'm not sure. Is it on my side or?
No, I'm back. Sorry.
No, it's okay. I'm asking, is Taiwan a good place for tourism?
Yeah, it's very nice, and the public transport is good, and it's actually very safe. Nice. So if you travel alone or or ladies, it's very safe to walk around at night, and so there are a lot of places to go. Yeah, Taiwan's actually very good for tourists.
So please let us know if there is any scientific event in the coming few months, either online or physical. So we may consider visiting Taiwan.
For sure, yeah. We're at the moment being facing this Omicron. I think Omicron is it's going to hit us soon. So we're seeing a peak in our cases at the moment.
I see. Hopefully it will be the last.
Yeah. So we're not sure if we're going to go back into lockdown again. So we'll see in the next couple of days.
Yeah. Okay, I think we will start, Dr. Honda, because you are the first speaker.
Okay.
1 minute just to. The attendants will join us soon. Dr. Honda from Taiwan. He's qualified as general surgeon in 2005, passing Taiwan General Surgery Board exam, and is qualified plastic surgeon in 2007. Dr. Honda worked currently is working as a lecturer as a part-time in Tzu Chi International Medical Association team, and he's working as attending plastic surgeon and head of burn unit in Tzu Chi Dalian General Hospital in Dalian, Taiwan. Am I correct, Dr. Honda? Is that right?
Yes, that's great.
Yes, thank you very much, and please proceed for your first presentation.
Okay, Dr. Abi, thanks very much. Then,
You're welcome.
you need to allow me to share my screen.
Yes, 1 minute.
Okay.
Dr. Saad, can you transfer the host, please? Dr. Saad?
Dr. Abi, somebody from your side is going to need to allow me to share my screen.
Yes, I'm doing my contact, Dr. Honda. Just a minute.
Okay, great. Thanks very much.
Because I'm in a different city than the technician guy, the
Right.
doctor who's taking care of the technical issues. We'll just give him 1 minute more.
Okay.
Hello.
Yeah, Dr. Honda, just 1 minute. Dr. Raja, how are you?
Sir, sir is operating, sir. He will come in 5 minutes, sir.
No, it's okay. We will start with Dr.
Sir, can I
Honda.
able to share the screen, sir?
Yes, but we will start with Dr. Honda from Taiwan. Dr. Raja will be followed.
Okay, sir, fine.
Thank you. Did you get the host, Dr. Honda?
No, not yet.
It's just in a minute. He just
Okay.
catch it up. You are the host now, Dr. Honda.
Okay, let me try again. Okay, excellent.
Yes, the slides are okay, but your voice is disconnecting.
And now, can you hear me?
Yes, it's okay now. Go ahead.
Okay, excellent. Okay, well then I think let's start.
Okay.
Dr. Abi, thanks very much for inviting me to this platform and talking about one of my favorite topics. So today I'm going to talk about salvaging the diabetic foot using a free flap. I work for a organization called Ciji, and it's basically a humanitarian relief organization. And we have 6 hospitals across the island of Taiwan. And my hospital happens to be on the East Coast. And we had the pleasure of having Dr. Roger. Dr. Roger actually came to our Ciji in Hualien a couple of years back for the Taiwan Reconstructive Microsurgery Society Congress. So we had the pleasure of having Dr. Roger with us on that day. So today, let's getting back to my topic. You know, when you face the diabetic foot and the patients are quite ill, it's often to know whether you are making a good decision. You know, the decision is always, are you going to, hi, Dr. Roger, good to see you.
Yeah, how are you?
I was
How
just
are you?
saying that we had the
Good to see you,
pleasure
no?
of being in the hospital.
Yeah, good. Good. No, sorry, I joined late. I thought 5 o'clock now, so then, I thought 15 minutes more there. Okay, great, good.
Look good. You look good. All right. I think. Let me carry on.
Yes, so you
Yes,
carry
go
on. No,
ahead.
please carry on. Please carry on. No.
Right. So as I was saying, you know, when you are faced with a diabetic foot and the patients are quite ill, it's always a difficult decision to make. You are faced with 2 choices. 1, are you going to salvage this foot? Or 2, are you going to amputate it? So, you know, this is what we often see in our emergency room or in our clinics. You know, a middle-aged patients coming with the diabetes, and they come into the emergency room, and these patients are feverish, they are septic, their blood sugars are off the charts, and you know, you look at these foot, you can see that there's wet gangrene, and if you look on the dorsal side, the 2nd toe and the 3rd toe are already really rotten, and the dorsal foot is very swollen. And if you look at the plantar foot, you can see that there's already pus formation all along the plantar space and then going into the medial foot. You know, so when you look at something like this, and this guy is really sick, you know, it's really a difficult choice to make. You know, what do you do in this case? So, sorry, I think my computer is now lagging. I think my computer has just lagged. Sorry, give me a second.
That's okay.
Okay. So when you're faced with something like this, you know, you feel like it's a mountain to climb. You know, if you're gonna do something about it, but it seems like such a long way for you to salvage this foot. So sometimes it's easier to take the straight and wide road. You know, it's easy to amputate this leg, and then you know, 2 to 4 weeks later, this guy will be back on his feet, and he's going to have a prosthetic leg. But then he's going to be minus a leg. And in our culture, our patients always they don't want to have their legs amputated. And I think it's very similar for a lot of the patients in the Eastern countries here. Even I can see Dr. Roger nodding. Even if you want to amputate a toe, sometimes it's very difficult to convince your patients, you know, you're just going to amputate a toe. So, but when things look impossible, you know, you always look for a way. And this is one of my favorite, you know, one of my favorite quotes, that nothing is impossible. You know, just when things look impossible, there's a way. There's always a way. And this is from a TV series called Grey's Anatomy from years back. So when you're faced with something like this, don't panic. Try and keep calm, and then think it through. Once you've done or two of these cases, you get more experience, then you know what you want to do.
Excuse me, Dr. Honda.
Yes.
We don't see your PowerPoint.
Okay. Let me try again.
Actually, I was seeing the last slide was keep calm, it's patient's life, right?
Okay. Let me try again. I'm going to share my screen again. Give me a second.
Okay.
Sorry, now I've lost my Zoom. Okay, so you can see the screen now.
Yes.
Okay, I think I'm gonna keep it on a small screen like this if that's all right with everyone. Okay, so when we are as residents, we often see this kind of a picture. This patient comes in for amputation of the one side, and then a couple of years later, they get amputated on the other side. So what we like to do is we like to try and keep our patients, the limbs intact. Okay, so in this case, what we did was we debrided this leg. We took the second and the third toes off. We tried to get it as clean as possible. And then what we commonly do here is we place them on broad spectrum antibiotics. We consulted the endocrinologist for proper sugar control. And then we did a normal saline wet dressing in this case. Once the wound was cleaner, we arranged for a ABI, ankle brachial index, as well as a PVR. And then we did an angiogram. So we consulted the cardiovascular surgeon for us. And they did a on-table angiogram. And you can see that after the popliteal, around the knee area, just below the knee, you can see that the triple vessel disease. Okay, so there's 3 vessels that you should see clearly here. And in this case, they are almost all absent. So you can see down in the tibial area, the anterior tibialis, you can hardly see it. And you can see a lot of collateral formation. So this is very, very commonly seen here. Right, so down to the foot, you can only see some dorsalis pedis and some posterior. This is just formed from a collateral flow. So what the cardiovascular, endovascular intervention here in Taiwan are often performed by the cardiovascular surgeons. So the cardiovascular surgeons, what they did is then they did a angioplasty for us, okay? And so all the way down into the plantar foot, they did an angioplasty for us. And then after angioplasty, you can see that good flow was obtained down into the foot. So after angioplasty, with further wound dressing, you can see that there was very good granulation tissue seen, and the wound was then much cleaner after normal saline wet dressing and broad spectrum antibiotics. All right, so the dorsal view and the plantar view. So in this case, we had a muscle flap, and we covered this with a skin graft. You'll see from my presentation that I do a lot of muscle flaps. We do some cutaneous flaps like the thin ALTs, but often we do a lot of muscle flaps. It's because I work in a rural hospital, and we are one surgeon that we start. We do everything by ourselves. So from the first incision to the last suture, it's all by myself. So the muscle flap to me is actually quite quick to harvest, and so we can do it in a short period of time. You can see that after a while, once the skin graft has taken, In this case, the muscle flap was not too bulky, and this patient could, after 6 months, there was, the flap has atrophied well, and he could wear his shoes well. So in this case, there was no problem wearing his shoes, and we could have salvaged this foot. So in our unit at the moment, this is our treatment algorithm. When we are faced with an infected wound, what we do is we perform a debridement first. If it's a non-infected wound where there's dry gangrene, so there's no rush to debride the wound, in this case, then we will arrange for a ABI and a PVR to be performed. So the ankle brachial index and the pulse volume recording will give us a good idea of how the distal circulation is like. If this reading is bad or is poor, what we do is we consult the cardiovascular surgeon, and they will perform an on-table angiography at the time. And if it's bad, they can perform an angioplasty or a stenting at the same time. And then if required, at the same period, we can do it in our hybrid OR. We would, after they've done the stenting or the angioplasty, we would debride this wound. And then once the wound is clean, we'll go for reconstruction. Okay, so now the question comes, is it worthwhile going through all this hard work when you know that the leg will be amputated at a later stage? So there is a misconception that primary amputation is a safe and appropriate solution. But in the critically ischemic limb in the elderly, there's a high mortality rate. So a lot of people previously would advise for primary amputation in these elderly patients. Okay, but we know that limb preservation is quite beneficial in patients' overall survival and also in their everyday activities. So it's actually very good for the patients. And like I said previously, in our country here, in our culture, our patients tend to ask us to preserve the legs as much as possible. Some of our patients will even refuse for a major limb amputation. They will go home and they will die in their house rather than to have their legs amputated. Okay, so Steve Moran and their group, this was in PRS in 2002. In their 10-year experience, when they're talking about peripheral free tissue transfer or free flaps in this PLD patients, they talked about having excellent rates. Okay, so now that we know that it's worth it to salvage these patients' legs, what is the long-term follow-up for these patients? Are they going to be amputated a couple of years later? So this is what this is actually the paper that got me interested in looking at our patients. Erkki's from Finland, I think, group long ago in 2006 in Annals of Surgery, they looked at their patients where they performed a free flap after a open bypass revascularization. Okay, and in that study, their 1 year and 5 year amputation free was actually quite good, was 70% and 41%, and the leg salvage rate was at 73% and 63%, 66%, and the survival rate was 91% and at 5 years. Okay. So why I looked at ours is what with the changing time.
Dr. Honda,
yes.
You can mute all attendants from your side as a host, so nobody can disrupt you except.
I'm not sure how.
Go to participant, then right mouse click, then mute all.
Mute all. Okay.
Yes.
Let me try. Okay. I've done that. All right. Let me carry on. Okay.
Yes, go ahead. Nice.
Okay. So with the changing in times, we will see that endovascular therapy is now more and more popular. In my hospital, I can count in one hand how many open bypass surgeries we've done in the past 10 years. Everything is now endovascular first. So patients come and they always they'll get angioplasty now instead of open bypass surgery. Okay, so what is the long-term result of looking at endovascular revascularization plus a free flap in the diabetic limb? And when I looked at the literature, actually nobody's actually really talked about it. All the papers currently has been focused on open bypass surgery. So we looked at our patients with the aim to see the safety and the efficacy of this combination and the treatment and long-term follow-up. So this paper was luckily to be accepted by the European Journal of Vascular and Endovascular Surgery a couple of years back. So when we looked at our patients for the past 8 years, we had 60 legs in a total of 55 patients. There was an average of 35 males and 20 females, and the age was about 66 years old. So you can see that the defects are located in various parts of the foot. A lot of it in the forefoot, but mostly it's in the mixed areas of the foot. So some of them will be in the forefoot, like the patient, some in the plantar. So there's a mixed area. So as you can see, we did a lot of muscle flaps in our study. We also did a couple of ALT flaps, and then the recipient arteries you can see are mostly the dorsalis pedis, the posterior tibial, the anterior tibial, and I like to use a lot of the greater saphenous vein as well. Okay, in this study, there was only 3 total flap failures, couple of partial flap failures, but only 1 major limb amputation. This is what I want everybody to focus on is the results. So the limb salvage rate at 1 year and 5 years are actually quite good. We had a limb salvage rate of 98% at 1 year and at 88% in 5 years. And the patient survival in the first year was 93%, at 5 years was 66.6%. All right, and the amputation-free rate at 1 year was 94%, and at 5 years was 68%. So this was very similar to Erke's group's results. But, looking at the survival rate of these patients, at 1 year, they got 91%, we had 93%, and at 5 years, at 63%, and we had 66.6%. So it's about the same. So you're looking at it, you're going to think, well, it's not too bad. But if you focus on this survival rate at 5 years of 66.6% or 63%, it's actually quite bad. If you look at some of the cancer patients, if you look at breast cancer patients or the colon cancer patients, their 5-year survival rate is probably much better than this. So I think, maybe we need to educate our patients more and see if we can prolong these patients' survival rates in the 5 years' time. So like I said, in our culture, what our patients believe is that what our parents gave them at birth, they need to take it with them to meet the ancestors. So it's very, very difficult for us to amputate part of the legs. Previous studies, some have recommended immediate amputation in some of these patients, especially with patients with renal problems. Some of the surgeons previously have advocated for major amputation. So with Ilick et al. And Saletti in 2001, this was also they also talked about in patients with poor renal functions, salvaging these legs are a strong contraindication. But in our group of patients, we had about 24 that were undergoing hemodialysis, and they also showed that the limb survival was also not too bad. So in other words, you could salvage these legs even if they were under hemodialysis. You can do angioplasty and you can do free flaps in these patients. So the advantages of doing an endovascular treatment is that in some of these patients, you don't need to do to perform it under general anesthesia. So you can imagine that some of these patients are actually quite ill and they are not quite suitable for general anesthesia. So in these patients, it's actually quite beneficial for us to do endovascular treatment under a local anesthesia as possible, or under a bit of intravenous anesthesia. there's no surgical wounds, or there's very few surgical wounds. In other words, there's only a puncture wound that's been seen. So the post-operative care is quite good. The 6 months, there's no significant difference in the amputation-free survival rate. And the 5-year hospital cost was also much higher if you did an open bypass surgery. So there's less chances of these patients ending up in the intensive care as when you compare it to those that had undergone open bypass surgery. So for endovascular angioplasty, you're allowing revascularization to a broader spectrum of patients. In our group of patients, we waited for a week interval after endovascular revascularization until we did a free flap reconstruction. This is to ensure that these angioplasty vessels, that they must remain patent and there were no acute thrombosis of these angioplasty vessels, or there were any interval dissection, because then this will put your free flap at risk. So once you know that you can do it, don't give up. I think this was one of my recent cases that came to me recently. This patient also came with a very, very bad leg. You can see that in this case, the 4th toe and the 5th toe are involved, and that there's necrosis of the whole of the dorsal foot. And you can see that there's very poor vascularization to this area. You can see after fasciotomy, there's almost no bleeding from this wound. Okay, so after a couple of more days, you can see that the necrosis has now extended into a bigger area. So in this case, we also had the cardiovascular surgeons to do angioplasty. So a stent was placed in the superficial femoral artery. And then afterwards, we did more debridement. And you can see that the plantar side was actually quite good. So after we've performed further debridement, the wound showed a good bleeding, and the wound healed quite well. But you can see there was still necrosis of the 2nd toe, so that we took the toe off, and then we did a free vastilis lateralis muscle flap. You can see that in this free muscle flap, I've left a skin pedal on. This is one of my favorite tricks to use when I use a free muscle flap, because when you do a free muscle flap, it's actually quite difficult to monitor the color of the flap once you're back in the ward. Of course, you can listen to a Doppler to see that that your anastomosis is patent, but in a lot of the cases, it's very difficult to monitor the color of this flap, of a muscle flap. So I like to leave a skin pedal, and then I can tell my nursing staff just to look at the color of the skin pedal. If the skin pedal looks fine, then that means my underlying flap is fine. So afterwards, we did a skin graft onto this flap. And then you can see the problem with the muscle flaps is once the skin graft has taken out, it's actually quite bulky. And then you can always reassure the patient that the muscle flap will atrophy in about 6 months' time. So within the 6 months, this muscle flap should atrophy to about 2/3 of its original size. So you can see follow-up. I think this is about 4 months later. I think if you look at it 4 months later, it's already atrophied very well. And in this case, this patient was already able to go out and buy some running shoes. And I think my video is not, this video just shows that this patient was now able to walk around with no problems. So as I was saying earlier, sometimes, if you look at this case, when you see the foot like this, you think to yourself, is it possible to really salvage this leg? So like this saying, I posted earlier, sometimes it just looks impossible. But when things look impossible, just look for a way. There's often a way to go ahead and do it. So for my suggestions in doing a free flap salvage for these diabetic foot wounds, especially for if you are maybe there are some of you that are plastic surgeons here, or some of you who are general surgeons with special interest in limb salvage. When you're doing a free flap onto these legs, first of all, when you do the free flap anastomosis to your native vessels, do it as an end-to-side anastomosis. If you do it as an end-to-end anastomosis to your dorsalis pedis or your posterior tibial, then you are actually sacrificing one of the major arteries into your foot. If you do that, your patients, the rest of your foot might get into trouble, because that might be the only major blood supply to the foot. And then you might be sacrificing it if you do it end-to-end. So it's much better to, even though it's more technically more difficult to do it as an end-to-side anastomosis, it's much better. My second tip is that to save the collaterals. When we're doing a free flap reconstruction in other areas, like in the head and neck, we often clip off the collaterals. It allows us to perform a much easier anastomosis for our free flaps. But in the foot, especially in the diabetic foot, we like to save the collaterals because if your free flap do fail, and sometimes they do because it's much more difficult. If the free flap fails, if the collaterals are still present, there might still be adequate blood supply to your foot and to your wound bed, that once with conservative wound dressing, they might develop enough granulation tissue for you to perform skin grafts or other easier forms of reconstruction later. I also like to transpose the greater saphenous vein as a recipient vein. Of course, you can use the comitant vein that is with the dorsalis pedis or the posterior tibial, but they're often quite small and the walls are very thin. If you transpose the greater saphenous vein, the greater saphenous vein gives a very good caliber, and it's much easier to perform a microsurgical anastomosis to the greater saphenous vein. There are a lot of free flaps that you can choose from at the moment. And like I said, I do a lot of muscle flaps because I find that it's easy and it's very quick to harvest. Of course, you can do an anterior lateral thigh flap. You can do a forearm flap. You can do what's very popular at the moment, especially with JP Hong. He does a lot of the skip flap. But I think if you're starting out doing free flaps, or you're just trying to salvage your patient's legs, do the flap that you're most comfortable with, the one that you're most experienced with. And in this case, you're probably going to find that your salvage rate, your limb salvage rate is much higher. Often in these patients, your recipient artery is quite atherosclerotic. In other words, you might open up and then you look at your recipient arteries and you can see that the whole artery is quite calcified. And so it's very difficult to perform a microsurgical anastomosis onto this calcified vessel. So look along the artery, and then you can see that maybe in some areas where there's less calcification, and then you do the anastomosis to this area. In this way, you will end up with a higher success rate. If the whole artery is quite calcified, then in this case, you're going to have to do an arterectomy. But when you do an arterectomy, then you should be prepared for a higher flap failure rate. All right, but I think in all cases, you need to know your limits. You need to know what you can do and what you can't do. So if you feel that you're able to salvage this limb, then I think by all means go for it. But I think in some cases, we are not all as talented as some of our fellow microsurgeons like JP Hong, where they're talking about super microsurgery. I don't think super microsurgery is for everyone, but you need to know what you can do. So if you are comfortable with doing microsurgery for limb salvage, then by all means go for it. If you are not so comfortable with doing microsurgery, then there are some local flaps or perforator flaps that you can rotate into the area for salvage, or if this is not available, then there are now more advanced wound dressings that you can use. These dermal matrices that you can use for wound care. So not every case you're going to need to do a free flap. If you can't do a free flap, then you can always look for alternatives, like a dermal matrix. I think they also work quite well. All right. So also you need to be prepared for when things go wrong. You need to have a plan B. So once your free flap fails, and sometimes they do, what you're going to do? Would you go for another free flap? Well, I think if the vessels are good, yes, then by all means go for another free flap. But if the vessels are poor, you often know this because when you're doing your anastomosis, you know that the vessels are good or bad. If you think it's really poor, then I don't think I would go for another free flap. I think in this case, I would remove the failed flap, continue the wound care, because these wounds have now been revascularized. So if you go for conservative care, with time, granulation can appear. And then in this case, you can do either a skin graft, or you do a dermal matrix, or you do a local flap. So you need to plan for things when things go wrong. All right. So just remember, if you're having a bad day, it can always be worse. All right. Okay. So this is the case when your patients are satisfactory to undergo major surgery like this. But you also need to know when it's not suitable to perform a major surgery like this. So if your patient comes in, they are in septic shock. They have a lot of life-threatening diseases. In other words, they have poor liver functions, which we see quite often here. A lot of our patients have hepatitis C, hepatitis B, and then liver cirrhosis. If they come in and they are needing high-dose inotropic agents just to maintain their vital signs, I think in these cases, it's safer to amputate and to save their lives. It's pointless going all the way to try and save the leg, and then you lose this patient. So if they're dead, there's no point in salvaging a leg. All right. It's also quite a lot of surgeries to undergo. So these patients need to be motivated. Their families need to be motivated. So in the Taiwanese culture here, and I think it's similar in the East here, the family always gets involved. You can tell the patients what's wrong, but often the families that come back and tell you, why didn't you do this, or why did you do that? So you need to keep the families informed of what you want to do. Because, like I said, these patients are gonna undergo revascularization, they're gonna undergo debridement, and often repeat debridement until the wounds are clear. And then after that, they're gonna have to do a free flap surgery. So you need to let them know that these patients are gonna keep on undergo a few surgeries before they can keep their legs. So these patients need to be motivated as well. Also, when the infection is so severe that once you've started debridement and you've done almost the whole of the forefoot, or you've debrided so much of the foot that there's nothing left to salvage, these are good times to walk away and not to do anything. These patients will benefit from having a major limb amputation. So I think the crux of my talk today is that the limb salvage rate in these diabetic patients are not as bad as what we would think. And also in patients with end-stage renal disease, in other words, in patients who are undergoing hemodialysis, performing endovascular revascularization with a free flap also gives you quite good results. So these results are not as bad as what was previously described by other surgeons. So I think in recent times now, in all our patients, we would go for endovascular revascularization and free flaps whenever possible. Okay, so even though to do a free flap onto endovascular revascularization, it's technically more demanding because when you do an open bypass, you are anastomosing your free flap onto a good, healthy vessel. It's more technically demanding when you're doing into an angioplasty vessel. All right, but the success rate is quite good. And so now we can provide our patients another treatment option in the management of the diabetic foot patients with extended tissue loss. So I think if you're interested and you're keen, I think the Nike advert is quite good. Just do it, just go for it. So I think just to remind everyone how we go about in our treatment algorithm, if these patients come in with an infected wound, debride them first. If these patients are going to be septic, debride the wound, get them out of sepsis first. All right, and then after that, go for the angioplasty, the stenting, and then reconstruction. If this patient's coming with dry gangrene, then there's no rush to debride the wound. In this case, do the ABI and the PVR first, and then go for the stenting and reconstruction, and after that. All right. So I think I hope everybody has learned something from my talk today, and I don't know if there's any questions from the participants today.
Well done,
Thank you.
Dr. Amanda.
Thanks very much, Dr. Abi.
Well done. It's really interesting. I'm really pleased to have this lecture because you discussed actually a few issues that we overcome. If you go to slide 62, your treatment algorithm.
Okay.
For infected wounds, if I may ask that sometimes the infection is not limited to the foot. Yes. And on many occasions, the infection is going up to the leg. Right. So what do you think about extensive diabetic foot with infection and pus and fasciitis or maybe myositis and the leg? Is this included in your treatment algorithm?
I would classify it under the infected wound. What I would do is if the circulation to the foot is good, then these patients always have a chance. If then I would do a wide debridement, do fasciotomies, and try and get the foot into the legs as clean as possible. We see quite a few of our fair share of our necrotizing fasciitis of the legs here in Taiwan. In these patients, just if the circulation is good, then don't be shy about the debridement. Just try and get the wound as clean as possible. Once you can get the infection under control, then your patient will have a chance. If you cannot get the infection under control, then it's very difficult to salvage this leg.
But does this include also osteomyelitis of the bones, either on the foot or high up, or you mean only the soft tissue infection? Yeah,
I do mostly the soft tissue infection. So for the osteomyelitis of the foot, if it's just the toe bones or the phalanges and the metatarsals, then these patients have got a chance. If the ankle joint or the tarsal bones are involved with osteomyelitis, then it's very difficult to salvage these legs.
I see. So what about tenosynovitis? Do you consider this a separate entity, or it is in the same line with your?
I consider this as the same line. With tenosynovitis, pustular tenosynovitis, deep plantar infections, these are all included in the same group of patients. So with deep plantar infections, tenosynovitis, pustular tenosynovitis, wet gangrenes of the toe, osteomyelitis of the phalanges and the metatarsals, this is all included into the same group of patients in the study.
I have seen that you managed the dry gangrene with debridement. Is that right? Do you debride dry gangrene of the foot, or you leave it?
Only if the patient's quite young, and I normally try and leave the dry gangrene. The cardiovascular surgeons, you need to get them to revascularize this leg. Sometimes after revascularization, the dry gangrene becomes wet gangrene. In this case, you will need to amputate it. If it stays dry gangrene and it's just the toes involved, then I would educate my patients to disinfect the toes every day, keep it nice and dry, and then wait for auto amputation to occur.
I see. Any question, Dr. Any question from the audience, Dr. Raja?
I think it's a wonderful lecture. And to answer your question, we also face these problems, extensive infection and all that. What we do is, I totally agree with Honda in the sense, if it is not life-threatening, then what we do is we extensively debride. And if that limb has got a blood supply, we give them a chance. If the limb doesn't have a blood supply, we try to get a blood supply. And if they are not possible, then amputate. Okay, you must have blood supply into the leg. And you must have a pulsatile, some flow into the leg. Once it's there, then we give them a chance, provided it's not life-threatening. So I think that's the same way we would also take the things.
But how feasible is to do angioplasty in the small arteries in the distal limb? Is it feasible? Is it easy?
Yes, you need a good interventional radiologist, and we find that infrapopliteal segment, if there is a narrowing, I think you need to do angioplasty, infrapopliteal segments. Whereas in the suprapopliteal segment, I think you do a bypass. If you have, I think that's what our vascular surgeons do. So it's quite possible to do. Previously, I also used to feel it's very difficult, but then some good interventional radiologists, they balloon it out, the carbon dioxide, they use that. And even people, otherwise, if you put a dye into people who are got a renal problem, then it's again a big issue, this angiogram. So they use CO2 and then they used to take it out. That's better. They still do. We always give a try.
I see. I think Dr. Richard from UK, he was joining us over the last 2 days. He has a question that he's saying, it's in the chat box. Thank you for an excellent presentation. Please, can I ask, what were the cause of death by 5 years, and did heart failure impact on survival? Dr. Richard Pacey from UK.
Dr. Richard, good question. Interestingly, they didn't die from the diabetic foot. A lot of these patients in this 5 years, they actually died because of acute AMIs and having CVAs, strokes. So they actually die of something else rather than from the diabetic foot. But once they develop a diabetic foot, you can see that these patients, their blood sugar are actually not so well controlled. Even sometimes once you've salvaged their legs, they go back, and these patients, I don't know, I think we need to try harder educating them on proper sugar control, because they often still come back with poor sugar control. I think in my talk, I talk about educating families. This is very important in the Asian culture, because when there's a medical legal problem, it's not the immediate family that comes and sues you, it's often the extended family. So now when these patients come in with a poor vasculature and diabetic foot, in the first meeting with the families, I tell them that they are at high risk for having a stroke, even while they're admitted. And they need, I often say, if your vessels to the legs aren't so good, then the blood supply to your heart and to your brain can't be much better. So I need to tell them this, but that's actually very, very good question, sir.
Can I ask, have you had the chance to see how the mortality compares with matched diabetic persons without foot problems?
No, I actually, because our patient was quite low, that we only had about 55 patients, but I think that's a very good question. And I think maybe we can look at using a larger database in Taiwan, the government database. Maybe if we look at that, we can do a matched study.
Thank you very much. It's a fantastic talk. Thank you.
Thank you, sir.
I just like to add to Sir's question. In our people, we found people who had an amputation of the major amputation, below knee or above knee amputation. And many of them got involved in urinary tract infections. I think that's urinary sepsis. That's again a problem. Whereas now, when there is mobility, we found they did not have it. When they lie down, somehow we found that the chances of increased urinary tract infection leading to urinary sepsis and mortality. In addition to the usual myocardial part of it, these people are also prone to urinary sepsis.
Right.
Thank you very much, Doctor. Any question from the audience? In the chat box? Anybody? Well, thank you very much.
I just want to take this opportunity just to remind everyone, if you look at the 5-year survival, 66%, it's really, really bad if you compare it to some of the cancers that we see. So I think if everybody that's in this group at the moment, they are interested in diabetic foot, I think maybe we need to think about how to improve their 5-year survival rates. We can save the legs, but how do we improve their 5-year survival to be, it's at present, it's worse than some of the cancers that we see. Thanks very much, Dr. Abi.
It's a pleasure, Dr. Honda. We'll be in touch soon. I'll contact you later. I'm really glad and happy that you join us and share experience. Thank you very much.
Thanks very much.
Thank you. Dr. Raja, I think you are the next, is that right?
Yeah, that's right. Now, can I share the screen?
Yes, just give me 1 minute just to introduce you for the audience. I'm really glad to have Dr. Raja Saprathi from India. He's currently the chairman, Division of Plastic Hand Reconstructive Microsurgery in Ganga Hospital, Coimbatore in India, which is a 650-bed tertiary referral center for plastic surgery and orthopedic. Actually, your CV is long, but I'll keep the stage yours, Dr. Raja. You are already well known. You are the chairman for this meeting. So go ahead, please.
Yeah, I share the screen, Dr. Labi. Yes. Can you please enable me to share the screen? As host disabled, it comes.
Dr. Saad, please share the screen with Dr. Raja. Dr. Saad. Yeah, 1 minute.
Yeah.
Yeah, 1 minute, Dr. Raja. Sorry for this.
Thank you. No problem.
Yeah.
அவரு டிஸ்ட்ரிபியூட் பண்ணிருப்பாரு. இல்ல
I'm trying to contact our colleague, but his
Okay.
phone is not replying. So I'll just give him 1 or 2 minutes extra. Otherwise, we may have a break, forced break for 5 minutes. Fortunately, I'm in a different city. I'm not in the same office. He's in Riyadh, and now I'm in Hail City, which is the host city for this event. To be honest, this event is fruitful, and today the media, the TV, they made an announcement for this meeting. Everybody's happy about the speaker's level of expertise and knowledge. And we are willing to expand this for yearly event, if this is possible, of course. With yes, you are the host now, Dr. Raja.
Yeah, good.
I tried my best to make you the host, right, Dr. Raja?
Yeah.
So who's the saver? Is it Dr. Honda, the saver?
Yeah, I realized I could make you the host as I was the host as well.
Okay, so Dr. Raja, you should transfer the host to the next speaker.
All right, okay.
This is
Thank you.
the safe mode.
Yeah. So you're able to see, you're able to hear me, see me? Right.
Yes, fantastic.
Yeah. So thank you so much, Dr. Alabi. It is a pleasure to talk about this. I particularly chose this topic because all of us now reached a stage where we can heal the ulcers. Now we started trying to think, how do we prevent the ulcers from occurring, and how do you do this? Because as all of us know, this is a huge problem. I think in India, now it's becoming a diabetic capital of the world. And as Dr. Honda told us, and 15% of the diabetics develop ulcers, and 3 to 4% of the individuals get the foot ulcers. And apart from traumatic amputations, the 85% of the non-traumatic lower extremity amputations occur in diabetes. And once they get a diabetic, their lifetime, is really curtailed. I think that's the real thing. And we know, as Dr. Honda told, we also keep telling people that the results of their post-amputation life is much shorter than many cancers. I think that if we put it that way, people get, oh my God, is that so? So that's the way we are doing this. And then what's really troubling a patient is that you have an ulcer, somebody comes with an ulcer, you heal it. Then they come with a recurrence. You do a complex procedure, then we get a recurrence. And then it frustrates the patient and frustrates the surgeon. And for the physician, the problem is They think, oh, refer to a surgeon and then this thing continues. So what they try to do is they do different medication, different dressing materials, and they think, why you refer at all? So defer surgery and they go into amputation. So this is a real problem. So we thought the goals of therapy for a physician is to prevent the ulcer, for a surgeon, heal the ulcer and prevent the recurrence. This becomes very important if you are a very busy unit. If you say that the recurrence rate is about 10%, and if you see 10 cases, then you get 1. If you are doing 100, then you become 10. And then every third day, you get a problem. And they keep adding up. And in outpatients, becomes a lot of undissatisfied patients we have. So we really thought over as to how do we do this, and that's the way. The most important thing we have to realize, and then which we realized and which we are happy about it, is most ulcers happen due to alteration in the biomechanics of the foot. In a country like India, you find most of them happen in neuropathic foot. So vascularity will be there. These people will come with ulcer. But then if you see the dorsalis pedis will be there. It is that's 85% of them are like that. So if you detect the alteration in the biomechanics early, that means you can correct it and prevent an ulcer. And when ulcers happen, along with whatever you do, plastic surgical procedure you do to heal the ulcer, you also need to address the altered biomechanics of the foot to prevent the recurrence. I think that's the point. So what we should do, I think first is that we should go all out to get the early warning signs. We should understand the precipitating factor and attempt to correct it. And you need to detect the impending problems early so that you've got time enough to manage it very well. So what are the early signs which you want to take is that we always know in our clinic we use 10 grams Siemens Weinstein monofilament. And if anybody has got a loss of protective sensation, that's one. That's the early warning sign. Number 2 is that the stiffness of the ankle and the first MTP joint. I think that's very important. Sometimes, the MTP joint, it may be very pliable in this position, but then when they walk, you'll find they may become stiff. So normally when you walk, the ankle is dorsiflexed. And in a dorsiflexed ankle, then you try to move, it doesn't move. So I think this is the problem. I think if it doesn't move, when they lose that pliability of the first tarsal metatarsal phalangeal joint, that means these people are prone for ulcer. I think that's very important. Third thing is you see a diabetic and they got a callus. That means it's a warning sign. Because callus increases the pressure on the underlying skin by about 30%. And uncorrected pressure leads to formation of subcallus. You have a callus, you just remove them, you find a small ulcer, you'll find. And this ulcer is not infected. It'll be like this for some time. And suddenly one day you will find, suddenly all these things become a big thing. And the fourth thing is, if you are not feeling the pulses, that means they are grave risk, and you must send them to a vascular surgeon for a consultation and try to get the blood inside the foot. So what we need, I think what we did was in our center, a treatment-oriented way, we divided these people, and we wanted to divide who would need surgery and who can be treated conservatively, and also useful for referral. So we divided the patients. Of course, this thing which is got many classifications. I think this is what we followed. The first is a foot tetris. There is no ulcer, or you got only pre-ulcerative stage, like callus. The second one is, you got an ulcer, but it's an uninfected ulcer. You got invasive infection. Third is a crippled foot, where you need to do a lot of debridement and you do need to do reconstructive surgery. And the fourth one, you need to amputate this waist just to save the life. I think these two. But then if you see a busy unit, even like ours, we found that 70% of the people reached our center in 3 and 4, critical foot, where you need a major job to be done or you need amputation. But what we did was we tried to make a campaign to find out we need to get these poor people in class 2. I think as a surgical unit, you need to get it in class 2. There got an ulcer, there is a problem, but it's not complicated. See, it's like this. This is a foot tetris. There's no ulcer or just the impending ulcer formation. There's a small callus. This is a foot tetris. And this is the guys, you find this ulcerated foot. They'll be going on like this for ages. They'll be going for months, for years. And suddenly, they'll get infection. So this is the group which we really want to highlight. I think we want to catch. This may occur in any places, many places, and every place it occurs, it has got a problem. It has got a specific reason why it happens. So, and then this is the problem happens. So usually, can they come like this? They got ulcer. You need to debride. It becomes a very big wound, and then you need to do a flap or a graft. We do. And the stage 4 is extensive infection. What Dr. Alabi said. Now, what do you do if you get a very necrotizing fasciitis? These guys, you need to really amputate to save their lives. Okay, that's right. So if you see them, they are at a foot at risk stage. It's a preventive podiatry. And the grade class 2 is surgical offloading. I think that's what I like to talk today much. 3 and 4 and now debride. I think Honda talked about it now very nicely. I think that's the way it should go. So what is that now? We have a team which does we can debride the callus. We keep them because they are neuropathic foot. They don't sweat. It's not moisture is not there. So they become dry. So moisturizing creams we use. We use a lot of offloading devices. We do. And we use customized footwear. I think these are the 4 things we do. So we have a unit now where when they do this stage, then we see a footwear, and then we ready-made footwear we use, and then the prescription footwear is given. They're made to order, and it is exclusively done for all of these people. Then next thing is that this will go from the bulk of the talk, that the surgical offloading. So we find out where is the ulcer, and we'll tell you what is the problem in each of the ulcers. Why it is like great toe, minor toes, forefoot, midfoot, heel, dorsal. So if you take a great toe, it can happen in 2 places. One is the IP joint ulcer, as you see on the left. The other is a subungual tip ulcer. So if you take an IP joint ulcer, why it happens is that because of the first MTP joint is getting stiff. So it can be stiff because of the plantar fascia, it becomes stiff, intrinsic ligament tightness becomes stiff. So when they have a dorsiflexion, this one points down, and that's the place where it gets the brunt of the pressure bearing. So in selected cases, what we do, we don't do much to the ulcer. We cover it up, and then plantar fascia. You cut the plantar fascia. I think that's exactly what we have done here. We cut the plantar fascia. It slips up. It goes back, and the same thing. That's where we operated. That's the ulcer here. This is heel. This we do in a few cases, but then in most of the cases, what we do is we do a callus arthroplasty. Callus arthroplasty is an operation that is done for ulcer in the IP joint. It's done on the dorsum. You do a small debridement of the wound, ulcer, and then we take the base of the proximal phalanx. I think you excise the base of the proximal phalanx, and then it becomes an arthroplasty. Then it becomes loose. So it is tight, it becomes loose. So if you radiographically, if you see, you will find this is what you will find. But then once you do this, what happens is that the same ulcer, this is the chap whom we have done it, and it goes on for healing. This is the X-ray of a callus arthroplasty that's happened. If you have a tip ulcer, that means it's because of another reason. It is because of the flexor, long flexor of the great toe, that's tight. Because it's tight, if you see the foot, you'll find the ulcers that are tipped. So what does that mean? It only requires a small and local anesthesia. You make a small nick and use an 18-gauge needle. We keep on keep the foot tight, and then keep on scoring. And FHL, you just cut it off. Once you cut the FHL, I think it goes on for healing. See, without doing this, I think if you do anything else, they all recur. So if you take the lesser toes, you've got 2 types of deformity. You need to assess the deformity, whether it's a claw toe or it's a mallet toe. The claw toe has a natural, it's got a hyperextension here. If you have to play this like this, mallet toe, this is straight. PAP joint is straight, but then this is straight. I think each of them will have a different tape. If you have a claw toe, what we do is what is called a girdle stone specific. This is just available in the literature. We do a girdle stone specific because what happens if you have a claw toe, this keeps on hitting the ground, and then that's the reason why they develop an ulcer. So that's what a girdle stone specific is done, and same patient. See, now because we do that, we get a normalization of the pulp to floor contact. So I think that's what is now important to prevent an ulcer. Otherwise, they keep on getting ulcer. Mallet toe, again, what you do, like a tip ulcer, whatever we do for the FHL, if you got a tip ulcer in the great toe, you cut the FHL. If you have got this thing, FDL tenotomy, flexor digitorum longus tenotomy. There again, a small incision, local anesthesia, cut it off, and then they go on to healing because it no longer is a pressure point. Next, you come up to the forefoot ulcers. Why do forefoot ulcers happen? I think that we need to know. That's because the triceps story or the gastrosoleus, that gets tight. In tendo-Achilles gets tight. So because it gets tight, when they walk, what happens is that the heel does not strike well, and the high stress goes into this. So once we understand this, if you try to, you get any chap with a forefoot ulcer, you try to dorsiflex, you feel it tight. You just need to really just cut the gastrosoleus. So here you make an incision, you cut the tendon. So he's got a forefoot ulcer. So what we do is now we take this and then we cut up all the fibrous tissues that the tendon it just slides off. And then they go on for healing. You will find because once you have got this, before that, see there is no weight bearing in this. So this is a gastrosoleus recession because gastric release. So here there is no pressure at all. Now you will find the heel's pressure, the pressure gets down here. So you do whatever you do for the ulcer, but please do this too. Without doing this, it won't happen. So here you find, you can rate a ratio, preoperatively you find, postoperatively the pressure is, the ratio is not high, weak forefoot, the hind foot, you will find it. Then we come to the other group, where you find metatarsal head ulcers. If you find metatarsals, you think it's not a forefoot, but then it's that you find only a prominent metatarsal. Then what you do is just exactly like a callus orthoplast, your metatarsal head, prominent metatarsal. You just do the same thing in metatarsal head excisions we do, because that's the one which is jutting down. Sometimes when you do this, you will find it gets on to the other toes. Sometimes the transversal ulcers we call them. The next one, if it gets prominent, take that too. I think that's the way we do that. If you get it in the first metatarsal ulcer, first metatarsal head, you can't take the first metatarsal head because it's important weight bearing. Then for that, you need to do a Jones procedure. I think that's what a tendon transfer procedures you do, so that you instead of having a lot of extension here, that it pulls up the metatarsal up. I think then it starts healing. Then you come into midfoot ulcers. Midfoot ulcers, most of them are due to Charcot collapse. I think the whole the midfoot collapses. I think that's the reason you get ulcers. You need to really investigate them as to find you do a lateral on standing plate X-rays you take, and you take the Mary's angle. We call that one drawn along the metatarsal, other is to the talus. If it is more than 15 degrees, it's called mild. It's moderate and severe. You decide. And this is also divided into of stages now. Stage 1, stage 2, stage 3, we do that. And if you see early stages, what you do is for this patient, what we did was we do an arthritis. The bone stock is good. That means we get our orthopedic surgeons to fix the bones, and you also plus or minus gastrosoleus resection is what is done. And if you find on a lateral X-ray, you've got a lot of bony prominence because due to collapse. Then what you need to do on the side, you open up and take away the bony prominence. You shave away the bony prominence. And then, then give a footwear, it becomes much better. So this is exactly what we do. You shave away the bony prominence, and then, you do the ulcers, whatever you want to do, it heals. Now we come to the heel ulcer. This again is the one group which is really important to find in diabetic people as to how we can, help them. See, here is a patient who's got a heel ulcer. We have debraided him well, and then we put him in a graft. But then we have not done anything to correct the problem what he had. I think we have not done any problem, correct the problem he had. So he is happy at this stage, but then he comes back. He comes back with this. So the reason why they develop a heel ulcer is because the tendo-Achilles in these people is very lax. I think that the dentist is very lax. So what happens? The dorsiflexion deflects, but then they walk on the heel. I think they walk on the heel. So if you have a tight tendo-Achilles, you get a forefoot ulcer. If you have a very lax tendo-Achilles and the dorsum is tight, then you get a heel ulcer. If you really find in these people, you will find that the heel bears the brunt of the weight. I think it bears the brunt of the weight. And normally, we should all be able to do this. Normally, people should be able to do this. But in people who have got a very lax tendo-Achilles, I think they will not be able to stand like this. So that means these people are more prone to develop the heel ulcer because the weight bearing, as in a walking stride, you will find they bear the weight on that. So what we do is now we tighten the tendo Achilles. We tighten the tendo Achilles or reconstruct the tendo Achilles. You find once we do that, there's a pre-op. So there is no weight bearing in the forefoot. So it's all concentrated over here. And then as you see, it's a 3 months post-op, 6 months post-op, 8 months post-op. So progressively, we found that it takes about 10 months to get it all. I think 10 months, it should get all. So you see seriously, serially when you see, then you get this. So that's it. So how do we shorten it? So here is a heel ulcer. You find this got tendo Achilles flag. We put in a Y-like incision and then close it like a V. So that means it become more tighter. So this is done when the laxity is very less. That is intact. The whole apparatus is intact, but then this is what you want to do. But then if the gap is high, if you want to restore the gaps, now we could use a fascia lata and then put in a flap over this. That's the next possible. The third alternative we do is that now we do the FHL, flexor hallucis longus. Now we cut it and take it, and we take it out, go it through, pass it through the bone, and take it back. I think in this way we find is real strong. This thing. This is what you could make. So once you make it, you will find tendo Achilles. Once you transfer it, if you take a pedograms, you will find there's so much pressure over there. In 11 months post-op, it's nice. Okay, that's it. Unless you do this, you do all the things what you need for the ulcer, but then you should do the next thing too. So sometimes in some patients, when you can't do this, we do the ankle fusion. You say you got a problem here, we have done a rotation flap, we have done. The flap is nice, but then if you want to keep it nice, you have to think why it happened, and then correct the problem too. Dorsal ulcers mostly are due to infective. I think it may be a common thing is paronychia or a new chapel, new shoes. I think that's the common thing, and usually they require debridement. And as in the previous talk, if you have this, if you have a producer, give them a chance. You really radically debride. I think most important thing is to debride them radically. Courage in the confidence in your reconstructive capabilities, it gives a lot of courage during debridement. So that's exactly what to do. Say we are at a problem and then we extensively debride it, put in a graft, because that should be fine for this. And here you find you got a heel ulcer you have got, and then we have put in a medial plantar artery flap, island flap, totally islanded, rotated over there, and that's the long-term result. And the instep flap, now you get a graft over here. Can free flaps be done in diabetic foot? And the previous speaker also told, yes, they can be done. We just need to have a vessel to plug in. So here is a bad wound that comes up, we debride very well, we find the vessels are good. Good means reasonably good. Okay, good, and then we took the gracilis. Our choice is also for muscle flaps because they're going well, they're easy to do, quick to do. Okay, that's the thing we do. So it's fine. And ischemic ulcer, there's a question Dr. Alabi raised, I think, where if you have a vascular problem, what do you do? If you have suprapopliteal problems, the segment stenosis, I think angioplasty or stenting we do. Here, sometimes we put a bypass, okay, they will bypass. And most of the times nowadays, our people are doing interventional radiology. Interventional radiologist does the job. So here we are antitibial bypass with the vein graft is used. And after that, vascularization is good, we heal with the graft. Can you do free flaps after revascularization? Can we do? Yes, we can. See, is the 70-year-old female, this is the pre-op angiogram. You see, post-angioplasty. The post-angioplasty, this is the one, that's the type of thing you had. And when you do this, when you get a good runoff after the pre-op, post-op, pre-op, post-angio results, and very soon after that, you must do a free flap. I think sometimes they may close afterwards. So if you feel a good pulsations come up, and then what you do is you must do a free flap. Here again, we've done a gracilis free flap to that, and that's the long-term result. But once you do, again, the footwear, all the other procedures you need to do. Dorsum, infective, you done a anterolateral typhoid, thin anterolateral typhoid has been done. So that again gives good results. If you have an advanced childhood osteopathy, unstable patient with sepsis, diabetic patient, comorbids with renal disease or with end stage with a very difficult cardiac problem, that means amputate. I think we shouldn't think amputation as a disaster. So what we do is that we do an appropriate surgical procedure according to the stage which they present. But then we feel our responsibility is to catch the people who have got an ulcer, but which is not infected. And according to the position of it, we should do. And we have written our ideas in our Indian Journal of Plastic Surgery. It's a freely downloadable thing, healing ulcers and preventing recurrence in the diabetic foot, which we have put in all our thoughts of this last 15 years. So we need to collaborate with a lot of people, medical diabetologists and surgeons, because at a stage where we think we can do a lot to them, they are not with the surgeon, they are with the physician. So we tell them improves the quality of life of the patient, improves the lifespan of the patient, improves the total number of well diabetics requiring medical care. Thank you so much, Dr. Alabi, for giving this opportunity. I really am very grateful to you for this. Thank you so much. And stop my.
Thank you very much, Mr. Chairman. Well, your presentation is outstanding because it's touching the pathway from all aspects, either from general surgery, orthopedic, pediatrist, all specialties are all in one lecture. So it is really impressive. From other aspects, do you think that Charcot joint can fit in your pathway or your classification, either infected or non-infected?
The Charcot joint means if we like to find out where the bone stock is okay. We first find out whether the bone stock is okay. If it is there, then we seek the help of our orthopedic colleague to find out now if fusion is possible. Fusion is possible. I think that's what we do. So,
can mute.
Is there some question?
No, you can mute.
Artık vereyim mi?
Yok artık ne lazım? Bakın görün de yaxşı tapım alın.
Koy onu da artık vereyim. Bak
I think this is a side topic, Raja. You can mute all from your side.
Can you mute all? Yeah, I'll do that.
Go for participant. Go for participant, right side.
Yeah, I put mute all, yes. Yeah, I muted all now. Yes, sir. I muted all.
Okay.
Yes.
Okay, so go ahead. Go ahead.
Yeah. So we, as I showed you now in the classification, most of them we put in for we give them rest. We put them in a total contact plaster in the very beginning stages, and in the later stages we find out if it is a collapse and then a bony prominence is there. Then we shave out the bony prominence and then try to do, or else once we get that, I think they have to fuse the foot. I think that's very important. I think you need to have good orthopedic surgeons fusing the joints appropriately, and then give them a good footwear. I think that's the way we would take Charcot's joint.
The same thing, even if it's infected or multiple infection?
No, infection means you have to debride. I think if it is infected, that means we need to debride. I think then it goes through the whole problem, because Charcot foot is basically not very infected foot. No, it's not an infected foot. But then if it's the infection is super added, that means it goes on to the category of the infection. So you debride the foot and then you start ulcer healing procedures, grafts, flaps, debridement or VAC, and that procedures to do. So wound healing must be accomplished before any wound procedures can be done for Charcot. So you need to achieve wound healing must be that must be the prime thing that we need to achieve before any stability procedures can be undertaken.
The second question, how far you think the VAC machine would help your wound healing? Do you usually utilize it or not?
VAC? So
yes.
VAC will not be useful for a patient who's got ischemia. If there is ischemia, if there is a superadded ischemia in the ulcer, VAC will not be useful. So what we do, we debride, and we think that there are not many good reconstructive or plastic surgical flap options available right now. Then you think you can only you need to put only a skin graft as will be your option. And then if you put VAC, that means it helps us to hasten the process. So if I think, that I could do a rotation flap or an instep flap or muzzle flap, some muzzle flaps, some local flaps, free flaps, if they are able to, we think we are able to do, then I won't put a back. I'll go for that and finish it off. But I think those options are not there or it is difficult, then safely put on the back and get the wound optimized and then put a graft and get away.
Well, thank you very much. I think Dr. Richard, he has a question. Dr. Richard, please.
No, but I muted them all. No? Can I mute?
No, he can
Yes.
unmute. But anyhow,
It's
his
okay. Thank you very much for another wonderful talk, Dr. Raja.
Yeah.
Please, can I ask you, have you had the chance to study outcome for the various procedures you've done, the outcome for preservation of limb and good health and life in the years following the interventions?
Yeah, I think we have got a study going on to find out when you do a Keller's arthroplasty, how long do they remain this thing? I think towards the end of this, another 6 months time, we will have a very, very good this thing. But then what we have found is about more than 50 preliminary. I think more than 50% of the people similarly. If fellows, we had people who have IP joint ulcers but don't accept surgery, and people who accept surgery. They are people accept surgery. They have got better quality of life, and they are not having a recurrence. They don't go further. They don't go beyond. These people, we meet them who refuse surgery. In about 6 months' time or 1 year time, we have them with invasive infection.
So you have a naturally occurring control group.
Yeah, that's right. People know who will not get or not. But that number, the problem is those people who don't accept surgery, they don't really come back for follow-ups. That's good. That's the problem. Whereas people who accept surgery, we have them totally under our vision. So to get that matching group, that getting the numbers on this side up is getting that's the difficulty.
I think it's worldwide with diabetes. For persons who do not engage, their outcome is always worse.
Yes, yeah, correct.
Unfortunately.
Yes.
Thank you.
But then we found that because in a busy unit, we need to really concentrate. We need to think, why did the ulcer occur in the first place? I think that's a good question to ask. Why did it occur in this place? Okay. And there is always a reason why did it occur in that place. And you need to correct that cause. And if you correct that cause, that means the effort that you do to heal the ulcer, it makes it much, much worthwhile and long lasting.
Thank you very much.
Dr. Honda has put a great talk. Do you sometimes see ferrous lesions at the interface between the flaps and the normal skin? Yeah.
Typing mistake, Dr. Raja.
Yeah.
Great to hear from you. And then I've learned a lot. Actually, while you're here, I have a difficult problem that I often see is that at the interface between the free flap or the flap and the normal skin of the foot, or once you've done a skin graft and the normal skin of the foot at the interface, there's sometimes these patients that develop a varicose lesion, this friable varicose lesion. What do you do? I find it's a headache.
No, once they get it, treating them is very difficult. Whatever you do, it keeps on. I think it's because they say it's pathologically because the movement interface has become different. I think that's the reason they say the level of movement between the two things are different. That's the reason it happens. So what you do if you want to prevent it, when you do a shoe for them, chapel for them, at the interface where we have, you just put a silicone liner in the area. The linings, there's a margin, but it always comes between the graft margin and the normal skin, or a flap margin and the normal skin. Okay, is the differential gliding is what's called. So from the very beginning, you put on a small amount of silicone placed in that area, and then ask them to put on a socks, and then the shoes, whatever they wear, the incidence is much less.
Thanks very much.
That's a common problem all of us face. A difficult problem too. Yes.
I think, Mr. Chairman, we will move to the next, but I'm not sure, but
Yes.
you have to transfer the host. Dr. Thomas Serena, is he around? Dr. Thomas?
They can,
Thomas?
another person has to scheme.
I cannot see his name on the screen.
Yeah, Thomas Serena, no? Because from the United States, no, it must be early in the morning, around 6 in the morning, I think.
So otherwise, we have to shift to Dr. Dicker.
Yes, hello.
Yes, Mr. Chairman, please transfer the host to Dr.
The host, I'll transfer the host. Yeah, one second, I'll transfer the host.
Yeah, transfer the host.
The host transfer, 1 second. Yeah, one second, one of my colleagues, you know, I'm not good at it, but then no, I will do that. Yeah. Now it's changed, I think.
Yes.
Yes.
He's the boss now.
He's the boss now, yes.
Yes, yes, thank you very much.
1 minute, Dr. Just to introduce you for our colleagues. Dr. Elker, he's from Switzerland. He's 100% attending lead infectiology, lead infection control, lead clinical research, and Balgrist University Hospital and Zurich in Switzerland. Dr. K, he had a lot of achievement, like tutor professor in the University of Zurich and start working at Balgrist University Hospitals. He had a lot of accomplishment and publications. So thank you very much, Dr. Please proceed your presentation.
Thank you very much to everybody. Good afternoon, or good morning, or good evening. And
for everybody.
So I'm infectious diseases. I'm a clinical researcher. I will not talk about surgery, not at all the experience you have in your Congress. I will not talk about implant-related diabetic foot infections, which is a topic a little bit neglected in the academic field of diabetic foot infections. I will not talk about the comparison of conservative treatment of infection in the diabetic foot versus combined with surgery in selected patients without major ulcerations, without major soft tissue problems, and without major bone lesions. You might equally treat conservatively with antibiotics alone, as it has been shown in England, in Spain, or let's say in Turkey. In selected patients, the antibiotic treatments can be for bone infections in the diabetic foot as good as combined with surgery, but only in selected patients. So I will talk about the antibiotic misuse. Now you might say, I'm a surgeon, I'm not really concerned about the antibiotic misuse, but as a medical person, I personally think you should be, because the diabetic foot infection will increase in the incidence and prevalence all over the world. In every country you are working, we are expecting an increase of diabetic foot infections, which can double within 1 decade. Now, it's up to you and your teams in your hospital, in your country, if you want to streamline antibiotic therapy, or if you only concentrate on interventions such as surgery or revascularization or plastic surgery. If you decide for yourself that you want to give some efforts to reduce antibiotic use, I give you now in my talk 7 reasons why you can do it and why I believe it can be easily done. First of all, you have resistance problem in your countries. I think in Switzerland, in Saudi Arabia, in Asia, in India, you will have it. Indian colleagues love to publish microbiological results of diabetic foot infections. It's an example of Pseudomonas in India. About half of the clinical SUSH of their Pseudomonas infections are pretty resistant to the current antibiotics. And this resistance can happen very, very slow. Don't think that you have a resistance which is summing up over 10 years or over 20 years, and then you cannot change the resistance patterns within 1 or 2 years. It is wrong. Here a bad example because of the COVID situation in Italy. It is 2 years ago, COVID situation in Italy for the diabetic foot. It is a specialized center in the diabetic foot where the infectious diseases specialists were busy. So a lot of other specialists increased for the diabetic foot infections in the COVID period, Corona period, the antibiotic use, and only within some months you have a lot of more antibiotic resistance within the clinical parts of the microbiology in the diabetic foot infections. So resistance can happen and can wane pretty rapidly within 1 or 2 years. It is not only a question of decades. Then there is also for resistance problem. Then there are some publications in the whole field of orthopedic surgery, by the way, that resistant germs are more difficult to treat. At least they are more costly to treat, that's for sure. But there are some publications, even in the diabetic foot from Turkey here, an example that the resistant pathogen compared to the susceptible pathogen, even if it's the same pathogen, is more difficult to read and maybe related to a worse clinical outcome over some months. A second argument that you should try to reduce your antibiotic consumption is the trend in infectious diseases. I don't know how many infectious diseases colleagues are in your Congress now who are watching, but there is a trend in infectiology since 10 years or 15 years to reduce the duration of systemic antibiotics all over the entire field of infectiology. Here you have, for example, for bacteremia, gram-negative bacteremia, I don't know how it is in your country, there are a lot of efforts to reduce from former 14 days to 7 days now. Or even for every strata of pneumonia, there are efforts all over the world to reduce. Nowadays, academically speaking, you can treat a pneumonia 3 days or at maximum 8 days. Even in practice, there are a lot of much antibiotics given. But academically speaking, and according to current science, you can reduce the treatment of pneumonia to up to 3 days. So also in the field of orthopedic infections, which is my hobby, my main topic of research is the reduction of the antibiotic durations for implant-related orthopedics infections. You can reduce from 6 to 4 weeks, or for arthritis, you can reduce from 4 weeks to 2 weeks, etc., etc. Even for sacral osteomyelitis, just to make analogy with other bone infections other than the diabetic fields. The American opinion 2019 says if, for example, in sacral osteomyelitis, if the cortical bone alone is infected and the infection is limited to the surface, you can reduce the antibiotic durations up to 2 weeks instead of 6 weeks, and so on. So 6 weeks is the actual recommendation. There is a practice to give much more longer all over the world, but in the academic field of infectiology for diabetic foot infections, it is nowadays admitted that the maximum duration should be 4 to 6 weeks. There has been studies comparing 6 weeks to 12 weeks. It's a landmark study from Senville group in northern France, comparing with a small number of patients, only 40 patients, but still 6 weeks to 12 weeks antibiotics selected patients for bone infections. It is the same outcome. And the actual guidelines, be it the American guidelines, which are used all over the world, all the world guidelines recommend at maximum 6 weeks. Even if you make the analogy with osteomyelitis, the original recommendation has never been 6 weeks strictly. It has always been 4 to 6 weeks. And also in the American guidelines, in the latest one, for diabetic foot osteomyelitis, the official recommendation is 4 to 6 weeks, although many people give 6 weeks. So there is a lot of recommendation. You have a support from experts all over the world. If you want to give less than 6 weeks, let's say 4 weeks, you can do it. If you look at the retrospective studies, we have investigated, there are a lot of them. We have investigated if there is a minimal threshold. So if you can, with the complex pattern of diabetic foot infections with vascularization difficulties, with open ulcers, with deranged pathology and anatomy, if in this population there is a minimal threshold to define what should be the minimal duration of antibiotics for infections, and we couldn't find it. And I'm not aware of any study who can define in the diabetic foot a minimal threshold, because the problem is so multifaceted that antibiotics alone are not important. My proper opinion, the diabetic foot, even if it is infected and if there is no sepsis, for moderate infections in the diabetic foot, the treatment is 80% surgery and only 20% antibiotics. So, and also if you choose your pathogen, you can have a lot of pathogens in the diabetic foot. Which one will you target for? Will you target for the tiger? Will you target for the giraffe or for the ape? You don't know. You don't know. And the microbiology, which is the basics of an infectious diseases treatment, can change in the diabetic foot compared to other infections such as urinary tract infections or endocarditis. The pathogen can change. An example, if you have an open wound which is infected, you have polymicrobial infections. Here you have again an example from India. In the beginning, at admission at the hospital, you have this pattern of let's say bacteria in the hospital. Let's say, for example, 2% Pseudomonas infections and 7% Staphylococcus aureus infections in that hospital. And for the same infections, after 1 week, only after 1 week, if the wound is not closed, if there has not been a definitive surgery done, and there has been a selection on the current antibiotics, the microbiology may change. So the initial microbiology you treat during the episode of treatment can change in the diabetic foot very easily if there is an open wound or ulcer. And if you look at the microbiome, you never know how much bacteria you really have in the diabetic foot. Your laboratory gives you a certain amount of bacteria, but it is arbitrary. If you really look close, there is much more bacteria than you think. And even if you do surgery, a surgical debridement, it is again data from Switzerland. You have one surgery, you have one additional surgery, 2 additional surgeries, 3 additional surgeries. These are the numbers of debridements. And each one you made on the current antibiotics a new surgery or a new debridement in the operating theater. You, with the antibiotics you have given for the prior episode, you are selecting new pathogens. So there are always new pathogens. What I want to say, my take-home message here is in one sentence, then the bacteria you see at the start are not sure to be the bacteria during the treatment. And even if you think that you have treated the first bacteria in the start of the disease, you will have a new ones currently. If you have a lot of surgeons treat the diabetic foot and with a long duration of antibiotics, because they say, and they are right, that the disease can recur. You have a lot of failures in the treatment of infections. But I encourage you to look at your own failures if they are microbiologically the same. because you have a failure of multiple problems, such as the anatomy, such as the alterations, such as the patient's compliance, and so on and so on. But if you look correctly, you may be aware that at the same anatomical localization where you have a clinical failure, the microbiology could be different from the prior episode. It is an example from Aragon Sanchez, a well-known surgeon in diabetic foot infections from Spain, Gran Canaria, and he looked at his failures and he saw that microbiologically speaking, from all his failures of treatment, only 5% were due to the same bacteria as initially. 43% microbiologically speaking were reulcerations or a new osteomyelitis at the same anatomical site. Now, another argument, the antibiotic side effects. A lot of centers don't record the antibiotic side effects. You are all aware that you diabetic patients cannot support the antibiotics, especially if you give IV. There can be renal problems and so on. If you prospectively look at your antibiotic side effects, there are prospective studies of our own, then you will see that between 6 and 14% of your patients during 3 or 6 weeks of antibiotic administration will have significant side effects. 6 to 14% of all your patients, you are giving antibiotics for 3 to 6 weeks. Now, I am in infectious diseases, but I don't believe in antibiotics in the diabetic foot, unless you have sepsis with bacteremia. So antibiotics are very important, life-saving and so on. But a little molecule, 250 milligrams or 500 milligrams of a molecule will not cure the infection of the diabetic foot. It can help here in soft tissue infections, which are rapid. In soft tissue infections, which are evolving rapidly, antibiotics are important. But in such cases, you have already infections, you have a bone infection, apical bone infections, you can give antibiotics alone. It will do nothing unless you do surgery or offloading. So I hope I have convinced you that antibiotics, you should not rely so much on the antibiotics, and that you can even try slowly to reduce the antibiotics, at least in selected patients for which you are convinced that they will have a good outcome. You should not, and that's my message, give antibiotics because of a schema. So the people say, yeah, you have to give 6 weeks of antibiotics, so let's give 6 weeks of antibiotics for every patient. I think you can make, if you are really interested in it, you can make difference. You can start to reduce from 6 weeks to 4 weeks for selected patients, or even shorter. You have to evaluate. Are there studies? Yes, a pilot studies of our own. 3 versus 6 weeks of antibiotic therapy for debrided diabetic foot osteomyelitis, prospective randomized trial in Geneva with the same outcome. 3 weeks against 6 weeks. We did the same for soft tissue infections. I don't know which are the schemes in all your countries, but in Switzerland it was 10 or 20 days. For soft tissue infections that has been hospitalized in a hospital in Switzerland, 10 versus 20 days of antibiotics, the same results. And we are doing a confirmatory trial over 400 episodes of diabetic foot infections in Zurich at the Balgrist. And we are also addressing a little neglected academical or practical issue. Yeah, you do your amputation, you clinically think you are in the safe zone, but you might have still a contamination of the proximal margins of the bone. This is a risk factor for failure. It has been published as the proximal contamination of post-amputation bone of the stump is a risk factor of stump failure within 2 or 3 months. But now, do you give if you have here still bacteria, do you give 6 weeks of antibiotics or 1 week of antibiotics or 3 weeks of antibiotics? Nobody knows. Here in Zurich, we are doing a study comparing, randomizing 1 week of post-amputation bone infection, 1 week of antibiotics versus 3 weeks. And in the interims analysis, there is no difference. A little discussion, a lot of discussion is IV. Do you really need IV in absence of bacteremia or sepsis? Do you really need IV in a diabetic food with a lot of arterial insufficiency? It's an open debate, but in academic infectiology, it has been acknowledged since a lot of time that even in bone, it can be diabetic foot bone, it can be other bones, oral antibiotics can be as good as IV antibiotics. This is a Cochrane review of 2008. There has been also a huge multi-center study in England comparing oral versus intravenous antibiotics for practically all bone and joint infections, including prosthetic joint infections, saying that oral antibiotics can be, you can switch from IV to oral antibiotics very early in the course. In that case, it was 7 days. And we also did a lot of studies, retrospective studies in Switzerland. For so far, oral, even beta-lactam antibiotics are as good as IV antibiotics. So you can do antibiotics to a chip even in diabetic foot infections, because the infection is the tip of the iceberg. You have to treat the other problems, the surgical problems, the vascularization problems, and the compliance problems, the offloading problems first, and then you have a margin to reduce your antibiotic in the diabetic foot. But to reduce the antibiotics in your diabetic foot, it takes the commitment of all of you, and it takes the courage to try it. And we encourage you, if you want, to try to reduce, at least for a good subpopulation of your diabetic patients, the total antibiotic use. And with that, I thank you very much for your attention. Thank you.
Thank you very much, Dr. Okay. Mr. Chairman, any question?
Yeah, I think it's a wonderful talk. Dr. Okay, thank you so much. I learned a lot. And particularly one of your slides was very interesting to me. That slide was, you had a slide which states the first debridement, second debridement, third debridement, fourth debridement, different organisms.
Yeah.
That was a very thought. I have not read that, but so it was very thought-provoking for me. And was there any interval between those two debridements, Dr. UK? Is there any specific to intervals between the debridements?
I didn't understand. Pardon.
What was the interval between the debridements?
The indication for the debridements for the surgeons.
The interval, but the first debridement and the second debridement, how many days gap? The gap between debridements.
5 days. 4
or
5. Yeah.
Right.
Yeah.
So
if
that's,
you don't do
that's interesting.
If you do not planify your surgery, and if you not do the maximum, it's my opinion as a non-surgeon, if you not do the maximum of your planified surgery at the first instance, and you are not experienced surgeon, you should gain experience with the experienced surgeon before doing diabetic foot surgery. I personally think that diabetic foot surgery needs, even if you are a surgeon, needs 1 year or one or 2 years of experience in order to be very good and performant.
I totally agree with you. That's right. And it was very reassuring to listen to your talk, to tell us that we can switch on to oral antibiotics quickly, and also reduce the time of antibiotics, because we don't see any new antibiotics coming up. We don't see any new antibiotics in the pipeline.
Yeah.
So I think we need to be very careful with the antibiotics that we have. And we take your point that we need to use it very judiciously.
Yeah, thank you. Thank you. So I'm going off now.
Thank you very much, Dr. K. We'll meet you again. Thank you very much.
Thank you.
Please transfer the host to me, Dr. OK.
Oh. It is done. I don't know.
No, not yet. The host is still at your side.
No. Now?
No, not yet.
So I'm going off. I'm going off.
But before you go off, I would like to transfer the host, because if you go off, the host will be closed for everybody, I think.
Maybe it's because this is the last talk of this session that I'll be.
Yes.
So maybe
Yeah,
now we could finish. You could give the concluding remarks so that we'll have .uk still, and then you could finish this. Fortunately,
No,
that is his last talk of the day.
Yeah, I think just to make final checkup with Dr. Thomas. Is Dr. Thomas around?
No, I don't see the name.
Yeah, so I think he missed his lecture. So what do you think, Mr. Chairman? Are we done today? I think we did a great job today.
Yeah,
And,
unless anybody has got questions.
I don't see any questions.
Yeah, I think they're all happy.
They are. I'm interested to have your lecture again. Either send it to me by PowerPoint, or I think we have to chat again, because to be honest,
you recorded, no, Chairman. You recorded it, right?
It is recorded, yes, because it's really covering all aspects, and it has multi-dimensions plan. So it's really nice.
Because if you're running a big diabetic unit, and if you are just only healing the wounds, and then what happens is that this is very frustrating to have these people come back. So we found the best way is to catch them early. And in the next month, when the COVID subsides down, we are planning to have a big screening bus. So we'll go around the places, we do a screening camp to find out, we keep the diabetic food, see them, and catch them up when they say that they don't have a problem. At that time, we are going to tell them, no, we can help you, so that now we prevent the ulcers. So UK, I think you are transferred the host, I think. You are successfully transferred the host.
Yes, I am the host right now.
Yeah.
And then, because, one of the consensus of this meeting, we are planning to launch and to upgrade the service of the diabetic foot of the region. So all recommendations for all speakers will be taken in consideration, of course, from everybody. I think Dr. K was the last speaker for today. So thank you, everybody, for their presence and contribution, Dr. Honda, Dr. Raja, and Dr. UK. And we will meet again in another meeting. Thank you very much.
Thank you so much, and thank you for the opportunity. Bye-bye.
Bye-bye. Thank you.
It is, for me, it was very useful to listen to Dr. Honda and Dr. UK. I quite enjoyed listening to both of their talks.
Thank you very much.
Thanks, Dr. Raja.
Thank you. Bye-bye.
Bye.